This will require a little bit more attention and more interactive over there. Any point of time, if you lose the flow, let me know, because this will have a little bit flow over there. Whatever you miss, then the subsequent things we will not understand. We'll divide this topic into basics of peak pharmacokinetics, basics of pharmacodynamics, alteration of physiology related to the PK and PD in critical ill patient, antimicrobial peculiarities related to the PK/PD, application of altered PK/PD with antimicrobial properties in dosing of critical ill patient, examples of the few antimicrobial, and the summary. Again, this topic is important for your theory, full questions, short notes, for MCQs, for Viva, and clinical practice immensely. After this, you understood the way we manage the critical ill patient, especially septic patient, may be inadequate just because of either not understanding or misunderstanding of this segment over there, which probably your internal medicine physician or maybe a pulmonologist or maybe a surgeon is not at all having this idea, and probably by out of ignorance they manage the patient in a non-standard way. So PK/PD, pharmacokinetics means how body handles drug. That includes the absorption, distribution, metabolism and elimination. And pharmacodynamics, which we classically in our early part of the medical education, pharmacokinetics is what body does for the drug, and pharmacodynamics is the what drug does for the body. Here is a little bit different. Antibiotic actually not does for the body, they does for the agents, infective agents. So that's why the pharmacodynamics, we can't really use that definition directly. What antibiotic does for the body is actually what antibiotic actually producing their effect in terms of the killing the bacteria. Understood? Few definitions. Bioavailability, the fraction of drug reaching the systemic circulation from site of administration. Okay, most of the time we don't bother about that because we are giving the IV is bioavailability 1, that's fine, but when you are converting IV to the oral, then probably you require this knowledge. Second is the plasma concentration, that is the total. Why this definition is including here is the total, bound plus unbound. So we'll know what is the limitation of the therapeutic drug monitoring over here. So drug concentration in the plasma, it is a total drug concentration. Clearance again, like a creatinine clearance, it is not the drug, it is the amount or volume of the blood which is cleared off from this particular antibiotic or drug. And the total clearance is the clearance renal plus non-renal or other. And the clearance depends upon flow rate, whatever organ is actually clearing it. If kidney is clearing, then the flow to the kidney. If liver is clearing, then the flow to the liver. Fraction of drug and intrinsic ability of the organ to eliminate the drug. This is the important aspect. This will require a further elaboration subsequently. So at this stage, you should be very clear about the clearance. Any question, any query at this level, you should be able to clear it off regarding the clearance. Elimination rate constant. The rate of drug eliminated per unit time, how much is actually removed. So clearance and elimination is little bit different, though they looks like similar, but exactly opposite. That clearance is the how much amount of volume of your blood is cleared off, and elimination is the how fast drug is coming out from the body, and it is inversely proportional to your half-life. If clearance decreases, your half-life increases. Half-life, typically drug concentration, that is the serum drug concentration reduced by the half, and that is the net effect of, again keyword here is the all elimination processes. It will require the how your antibiotic is actually eliminated, the renal, non-renal. Steady state, when your elimination rate meeting the coming of the drug, then it is a steady state. So if you are actually dosing your drug in the same way which how it is removing elimination is, if it is matched, then your steady state will be low. And typically it requires the 4 to 5 times of the half-life. This is the normal physiological condition which we are talking about. And T maximum is the time required to reach the maximum serum concentration. Volume of distribution, that again important. First, volume of distribution, wherever you are actually reading, these are the apparent or assumptions. Nobody can really measure the typical volume of distribution over there. This is the theoretical volume that relates to the total administered dose. And the loading dose is actually the initial dose required to achieve the target plasma concentration. Okay, everybody is clear about all this thing is, even if the little bit I just recapitulate three things here at least: clearance, volume of distribution and loading dose. Simple, looks simple, but it will be important in our further discussion. Now, the how drug actually enter into the body. You give the drug dose, drug reach the concentration in the blood, drug concentration at the organ site, here organ site both the way, where it has to act and from where it is eliminated. The effect or action, outcome results. So initial two part is the pharmacokinetics and last two part is the dynamic. This is key slide here. The antimicrobial, based upon the overall their properties, whether it is a hydrophilic or lipophilic, we divide into, and the pharmacokinetics properties, the hydrophilic are having a small volume of distribution. Very, very important keyword here is the hydrophilic is having a small volume of distribution. Mostly they are eliminated by the kidney and poor intracellular and the tissue penetration. Whereas hydrophilic is having a large volume of distribution, primarily eliminated from the kidney, from the liver, and good intracellular and tissue penetration. Last column is the examples, you just pay attention. Lastly, whatever the important things which we divide, we'll discuss over there. And the critically ill patients, what happens, that is the key factor over here. In critical illness, your volume of distribution for the hydrophilic drugs increases. Whereas because lipophilic drug, they are already having all compartment in this thing. So there is hardly much change in the critical illness. So lipophilic drug will not have any change in the volume of distribution. Hydrophilic drug, significant increase in the volume of distribution. So before going to just have a MCQ by the memory, all are the hydrophilic drug except first is your meropenem, second is the vancomycin, third is the levofloxacin, fourth is the tigecycline. Okay, so 3 or 4 things we should remember over there. So we'll discuss what tigecycline is the lipophilic drug, all are the hydrophilic drug. Now this we are discussing why volume of distribution in critically ill patient increases. What happens? So what happens? Capillary leak happens, third spacing happens, volume of distribution increases for the hydrophilic drug. This is a typical pathophysiology happens. Then all the intervention which you do in response to treat the septic or septic shock, that also contribute for the increase in the volume of distribution. That is fluid resuscitation, extracorporeal circulations in the form of your renal replacement therapy or ECMO or whatever. Post-surgical drain also increases over their volume of distribution because that actually goes into that. TPN also increases, mechanical ventilation is also increases over there. Apart from that, hypoalbuminemia also increases the volume of distribution on those drugs who are actually dependent on the high plasma protein binding. So those who are having a significant albumin attachment over there, that also hypoalbuminemia increases the volume of distribution. Understood? And this is evident by this thing is we measure the volume of distribution meropenem in the normal healthy and the critically ill, it increased by the 2 to 3, 4 times. So this is a typical evidence over there. It was actually demonstrated. So this concept clear? Now tissue penetration and target site distribution. Impaired and delayed in sepsis and septic shock critically ill patient. All the tissue penetration is decreased. So one is your volume of distribution is increased. Now even you are getting drug into your plasma and the target organs, that is also decreased temporarily. over the time period. If normal healthy I inject it, it reach to the maybe in the few minutes, so it may requires the hour over there, or maybe a few seconds to minutes, so it may be a double for the critical patient, because overall circulation and there is certain other things was, so all these things important. Even your concentration is no. Tissue antibiotic concentration may be subtherapeutic even when optimal concentration are achieved in the plasma septic shock. So that's again important. They are the delay as well as the suboptimal. So even your concentration is optimal in the plasma, your target organ may not get adequate concentration of drug. Antimicrobial concentration in interstitial fluid may be 5 to 10 times lower in the corresponding plasma concentration compared to the healthy volunteer. So first it reaches less to the target organ, and within organ your interstitial fluid is also responsible for the actually clearing of the infection. That again less over there. So second concept understood, volume distribution and delay. Third is your clearance. Clearance increases when the cardiac output increases, and also augmented renal clearance, what we label it as a ARC. So paradoxically, initial phase of sepsis, because of the SARS and all these things, tachycardia, all these things causes an increase in the cardiac output. So technically your clearance becomes faster. You got this thing? This is the list of the who are at risk. If you get a short note, then probably you need to know. Otherwise, by combination, you can early part of sepsis, young patients, trauma patients where they have hyperdynamic circulation, burn, and all these things can cause. Up to here, all are with me? Now, one more concept, end organ dysfunction. So, whatever we read, that gives you idea you require more drug. Now, this concept is the over the time period, if end organ dysfunction happens, say for example, septic shock causes hepatic or renal, then the drug clearance decreases and toxicity happens. So, it is in the reverse order. But loading dose, nothing to do with the organ dysfunction. This concept should be very clear. So, this is the summation of what we read. Now, severe infection, SARS, vasodilatation, increase the cardiac output, leak, all the fluid vasoactive, increases the volume of distribution, eventually causes decreased drug concentration, especially hydrophilic drug. And organ failure, hepatic or kidney, is actually increase the drug concentration, especially the lipophilic if it is hepatic, and the kidney, then hydrophilic drug. So this side is actually demands less dose, this side demands more dose. This is the key slide. You must remember, if you get any question which I told you, the three part, not only antibiotic, hydrophilic, otherwise any drug and all these things, this would be a common. Now another concept, PKPD, indices of the antimicrobial activity. This is the peculiarity related to the dynamicity of the pharmacodynamic. That is a concentration dependent antimicrobial killing, that increasing concentration progressively enhance antimicrobial killing at the ratio of C maximum by the MIC. This is I highlighted in the red. This is the typical index, PKPD index, which these drugs is having. If this ratio is more, they will work better. Example, aminoglycoside. Time dependent antimicrobial above MIC. If time is more, then they will work better. Immaterial whether you more increase the concentration or not. That is the F here is the free drug. So I told you the plasma concentration is total, but when it comes to the efficiency or efficacy of the drug, then it is a free drug. So it is not the total drug of the time, it is the free drug time. F here is the free, more than MIC. And the few antimicrobial agents, they require the higher concentration as well as the longer duration. They are having both the things in their favor. That is called the area under curve over the 0 to 24 hours divided by MIC. So there are certain examples over there. So this is the information in this. So previously I showed the slide of algorithms of different drug which requires a more, which demand more dosing and the less dosing. That is the key slide, and this one is the key slide over here. So here you can see how your C maximum, area under curve, and the time. Now or intervention related to the AKI. In the presence of AKI, what happens, and the RRT. So AKI without the RRT, you know, the creatine clearance predictable and all these things you apply. If critically ill, you apply the volume of distribution increases, you increase the dose, and the based upon your kidney function, you can reasonably give you a reasonable dosing in the patient. When you combine with the IHD, then again you are having a tool. So again, but when SLAD comes into the play, SLAD is not equal to the IHD. Your duration goes longer over here. So just here clinical question is, patient in the septic shock, your antibiotic dose is due, say for example 10 am and 9 am SLAD is started. What will you do this dose which is supposed to be administered in the 10 am? Probably your nephrology colleagues say after the dialysis you give the 8. So what will you do? How many give? Rest of the people will not give. Okay. Among the people who are selected give, will they give in the same dose, half dose, or more, double dose? So the question here is, one, you require more information. The answer is, your question is not complete. So response should be whether the drug is dialysable or not. If it is not dialysable, then it's okay. If it is a dialysable and your patient is septic shock, you have to give drug depending upon the severity and how fast the drug is being dialysed. You may give the double dose, you may give the same dose, and this dose is eventually what will happen if you give the dialysable drug? You probably have to administer more drug. You require a little bit of financial burden, but you treat the patient appropriately, because once the drug is dialyzed, that time your infection in the patient is not actually under the influence of the antibiotic. So you are keeping actually off from the antibiotic for the 6, 7, 8 hours, which is a severe septic shock. That is the primary. That's why I use the word septic shock. Some other diseases which we may have a little bit more complexities. Understood this? So if it is more dialysable and patient is really having a primary problem with the infection, which is actually may result into the death of the patient, probably you have to give the double, and the once you complete, then you have to give again. Then the therapeutic drug monitoring. Okay, you understood this, how the SLAD can complex. So there is a complexity in the SLAD. Now the CRRT makes the things more complex, because we'll discuss how many things are over there. Once 24 hours, then the different modes, and how CRRT is filter type and surface area, blood and effluent flow rate, replacement of fluid setting, CRRT configuration, modalities, sequestration of drug molecule within the CRRT circuit. You understood this? Have you undergone do you have a fairly good idea about the different mode of CRRT? Okay, these points you are agreeing how this thing, and the filter used for the CRT is not same as the IHD. These are the high flux filter. They actually, their size is more, they remove the things, even the intermediate size. That's why the cytokines can be removed by the CRT, not by the IHD. So they remove your drug very fast. So having this idea, somebody is not having a kidney function at all, and we start the CRT, that means it is having a normal person, is not a good idea. You are getting my point? क्या रे भाई ये पूरा राउंड द क्लॉक चलता तो एक नॉर्मल आदमी की तरह हो गया, फिर तो नॉर्मल ड्रग दे दो. Things are not that simple. Probably you have to give a double dose over there, because now your CRT is removing. So it depends upon, and the mode is also depend upon. So these are the variables over there. Just I will not go into the detail, because you may not be having a very deep understanding of the modes of the CRRT, but the hemofiltration is having a pre over there and all these things. So you see the variables over there. Now here question comes, all this we don't understand how we apply. From here AUC, C maximum, which this is the theory part only, you will apply only when you are able to measure the concentration of drug in the serum. If you are not able to, so all are your theory part only. So based upon hypothesis, you can manage the patient clinically. What we are discussing is, if we are not monitoring the concentration of drug in plasma, drug means antibiotic, then all these things are the theoretical only. But still it appears in the exam, that's why we need to read it. Okay, so if it filtration, then the replacement fluid is pre-filter, then it dilutes, it will having a different impact rather than the dialysis and all these things. This slide gives you idea how the change in the mode of CRRT can affect the drug concentration. Okay, now the more complex over there, because that was a simplified drug concentration. Now my drug is whether the concentration dependent, time dependent or AUC. So based upon all that also, it gives you only when you in depth. Otherwise, just go through the what you can take the message from slide is every drug based upon the not only the clearance, because clearance is you already calculated clearance, that was the previous, so much complexity you calculated, and after that there is more complexity. Which drug I am giving, it is a concentration dependent, then you have to follow that part, first part. If it is a time dependent, then you have to follow the elimination rate and replacement. Both the things are over there. So much kind of this thing is over. But the message again is these are the ways over there. So that there every step we may commit the mistake, and if we give a just prescribed dose, which is a normal manufacturer recommendation, will not work over here. Now if we start the ECMO. So again here question can comes the drug dosing in the critical ill patient with ECMO. Altogether different. We just have an idea how the ECMO can affect. Increased volume of distribution due to the hydrophilic, because so much kind of a volume of distribution. Even the increased volume of distribution or decreased clearance lipophilic drug due to the surface sequestration. Just I am giving you 1 or 2 points only. Otherwise, it again having a separate discussion over there, because now the again CRRT is the veno-venous CRRT is different from the VA ECMO. So you understood these all are the complex thing, but these matters when the now when you combine the ECMO with the CRRT, your situation will be like this only. And lastly, if your antibiotic is beyond PK, like MDRO, XDRO, PDRO, typical example is meropenem. If your MIC is 16, then you give the double. This is the independent kind of this thing. And you will combine with those patients, then you really which double or quadruple and all this thing. So in this way, this talk was a kind of all the component. And lastly, specific drug. I'll go quickly. Just giving you a basic idea of the specific drug which you are commonly use. It may be helpful in theory and the exam. Aminoglycoside, hydrophilic, low volume of distribution. Typically we understood the C maximum is most important. Even you can given there is a number is given in the bracket. You understood. Once we measure, then only we actually find the number. Beta lactam, hydrophilic. Typically your time above the MIC. Glycopeptide, hydrophilic, but it requires a area under curve by MIC. 400 is the typical number over there. Daptomycin, both concentration and the time fluiding in the same way, area under curve by MIC. C maximum is also over there. These are the best one. That doesn't mean C maximum will not work and all this thing. The best one is the AUC by the MIC. TG cycling, it is different from the other drug. This is the lipophilic. Large volume of distribution, predominantly biliary clearance, and plasma protein binding is very high. So low albumin actually increases the clearance. You find if you review the literature, if your albumin level is low, failure rate of TG cycle will be increased. So people actually give the albumin to actually increase the success rate of the TG cycle, and that gives you idea of the over and above. And PK per targets AUC by the MIC and different for the different infection. Skin is having a more AUC by MIC than the intra-abdominal pressure. And typically, in nutshell, in clinical practice, what I come to conclusion is most of the time we should follow this dose rather than a 100 stat and 50 BD. Especially when patient is critically ill. If patient is normal, otherwise then you can. Fluoquinone, again, comparatively it is a lipophilic. So having both this thing is MIC, AUC by MIC, and gram positive, it is require less dose. But gram negative, it is a higher. So just a simplified version. If gram negative is there, your ciprofloxacin, you should 400 TDS, not 200 TDS. And levofloxacin 500 TDS. BD to TDS. That is the dose. Colistin having a little bit of complex over there. This is a 3-compartment PK. 3-compartment PK is, one compartment is the plasma, second compartment is which is having a static rate of absorption, and again the elimination and this thing is. But one more compartment which is taking the drug very slow compared to the other compartment, then it becomes a 3-compartment. One compartment is your plasma, second compartment is certain part of body tissue or organ which is taking the drug very fast, and third compartment taking the drug slow, they release the drug slow also. So therefore the colistin is a complex from the PK/PD point of view. Pro drug is already there, then it convert into the drug, then the free drug, then so much variability over there, then the 3-compartment. That's why there is a lot of complexity in the colistin. Voriconazole I purposely selected because all the antibiotic, they are again the same thing with the antifungal also. Why? Because we commonly use the voriconazole. Voriconazole is a very unpredictable PK. If patient really require the voriconazole and the patient is serious infection, then you must follow the therapeutic drug concentration of the patient. We assume we are giving the 6 milligram per kg or 4 milligram per kg. Most of the time it doesn't work, and very erratic. And we cannot take the very simplified all the time. We'll give the double dose of the patient. Not sure. So that is a problem for the voriconazole. Again, lipophilic, large, and hepatic clearance, and all these things are. And here, if you find the PK/PD target is C minimum by MIC, not here the C maximum. So if you measure, then you go over there. So in summary, conventional antimicrobial dosing regime may not be appropriate for critical ill patients, especially sepsis and septic shock. Major alteration in physiology and pharmacokinetics. Interventions further complicate physiology and pharmacokinetics. MDROs make matter complex. TDM may help, therapeutic drug concentration or level may help, but not ideal solution. Concentration at target site is better. If you are having a pneumonia and you are able to measure what is the drug concentration in the lung, that is the ideal one, but not feasible. So thank you again. Any question? Still people didn't come out from this complex topic.
Or they have understood.
Okay, thank you.
Thank you, sir, for an excellent talk.